people are getting scenarios more. Okay. So this is finished with the GI tract related sign symptom. Now come with there is some exception. I mean, outside of GI tract, there are some features that they can affect some other organs. They can affect some other organs. So what could be? Both of them can affect the joint. They can do arthritis. They can affect the skin. In skin, dermatology, inshallah, next week we have class. Erythema nodosum and pyoderma gangrenosum. Mostly, these two type of skin manifestation is important for your MRCP to remember along with IBD, both. Both can be associated with erythema nodosum, pyoderma gangrenosum. Just to have a quick look, what are those? I will show you the picture. This is erythema nodosum. This is like painful shin lesion. We will discuss about shin lesion. Shin means the leg, the shin. This is the shin picture, right? Both shins are visible here. Within the shin lesion, this is one of the important important disease that you will see in that shin, that is the erythema nodosum. This is painful, okay, reddened, and whenever it is gone, there is no scar. One of the most important association IBD. In your derma, again, we will repeat that. This is your erythema nodosum, okay? One of the important respiratory disease associated with erythema nodosum. Tell me the name of the respiratory disease. Actually, that is multi-organ disease.
Sarcoidosis.
Sarcoidosis, very good. So that is also an important association. And usually in MRCP, that part 1 people, you will get either sarcoidosis associated or IBD associated this nodosum, usually. This is the pyoderma gangrenosum. The word is telling you gangrene. You can see the blackish border. There will be gangrene in the skin, derma, right? So this is also mostly very commonly associated with your IBD. Okay, so this is another shin lesion. So whenever we will do shin lesion again in derma, we'll repeat that, inshallah. So this is one of the shin lesion, erythema nodosum. Another shin lesion, pyoderma gangrenosum. Both are associated with the disease that we are discussing today, IBD. Okay, this is two. So bones, we finish arthritis, it can be. Skin, we finish. Okay, there are some specific things that are more common. It could be in both Crohn's and Ulcers. These are actually common for both. That's why I have written this in the middle. Now come, you need to know which some extraintestinal feature that is common in Crohn's more. All the things with stone, okay? All the things with stone. So what are the stones? Gallstone, oxalate stone. Another is cobblestone. This is actually the cobblestone you will get in your endoscopy there. I will show you the picture. This is actually endoscopic feature. If you put a pipe through that GI tract, you can see this is the cobblestone appearance. So all the stone related things, very easier to remember that it's with Crohn's, commonly with Crohn's. So the other thing, ulcerative colitis, there has to be something else that you need to remember, PSC, very important. PSC and uveitis. Uveitis not that much coming. PSC, obviously, either they will give you a question from GIT to identify PSC. Okay, I mean, not GIT, I mean from your that gallbladder part, or maybe they will give you from this IBD part. So PSC is very much related with your ulcerative colitis. And U for uveitis, if you can remember, that is better. Okay, there was no question, just to give you, because nowadays a little bit uncommon questions, associations they are giving you, so I want to utter it. Okay, so extraintestinal feature, if you can remember this, inshallah, you can cover all the questions, at least from extraintestinal feature. Okay, so erythema nodosum, you can have question, pyoderma gangrenosum association, you can have question. Gallstone, you have question. Oxalate stone, you have question. Cobblestone appearance from the scenario, you have question. They are giving the scenario cobblestone appearance in the endoscopy. You are definitive. This is Crohn's. It cannot be ulcerative colitis. Stone, Crohn's. Stone, Crohn's, stone, Crohn's. That's it. PSC, blindly, it is. They want you, if any GI tract association, I mean the with PSC, that is obviously they want you ulcerative colitis. Okay. This is your intestinal and extraintestinal feature. Now come with the complications. Both of them, this is inflammation, dear. Anything, inflammation, if for a long time in our body, it can turn into cancer. Like hepatitis, viral hepatitis, or any kind of hepatitis. If there for a long time, we are telling that could be hepatocellular carcinoma, right? So this is also inflammation. So if it is long standing for a long time in your body, it can turn into colorectal cancer. Okay, but which one is common? That's what they want. We know this, right? So the complication, the colorectal cancer, more common with actually ulcerative. Yes, with ulcerative colitis. But if they're giving you fistula, obstruction,
Crohn's.
Crohn's. Okay, so, but it's not like that cancer cannot be complication of Crohn's. It can be, but I'm telling you, most common. Any inflammatory disease for longer time, it can turn into cancer. But in your question, you have direct question that which one is having more chance to turn into colorectal cancer. You will have both choice, Crohn's and ulcerative. You need to choose ulcerative. You need to choose ulcerative. Okay. Okay. Now come with which area of the GI tract they are involving. Crohn's, it is involving from mouth to anus, anywhere. They can skip. It's not like that they can involve continuously. No, they can, maybe some part is involved, some part is healthy, some part involved, some part healthy, or maybe continuous. But ulcerative colitis, usually this is continuous. And this is starting from the rectum, going up to ileocecal valve. This will be stopped. So they're not going beyond the ileocecal valve. This ileocecal valve, one of your question. Okay. Now, so this one, it will start from down, right? One of your question, what is the most common site of ulcerative colitis? Transverse colon, ascending colon, descending colon, cecum, rectum, rectum. Rectum is the most common, one of your question, place of your ulcerative colitis. Okay, so we finished the site. Now come, you have to do investigation, right? Now you need to do the investigation, obviously. So you will go for what? You will start with something radiological. You will do X-ray, right? Anything, abdomen pain, you'll do X-ray. When you are suspecting that it could be IBD, normal X-ray will not that much help you. Better that will help you with enema. Okay, so if you are doing, this is our CD, this is our UC. So from first to last, the left side is for my Crohn's disease, right side is my ulcerative colitis. I hope you are understanding that. Okay, so if you are doing here enema, small bowel enema, what you will get? Let me show you the picture so you will remember that. This is, can you see, this is the string. The string is coming from here. This is a sign. This is known as the contour sign. Look here. This picture and this picture almost same, right? This is the contour sign. This is the string sign. Contour string sign that you can get in your, if you are putting that enema inside